Hey guys, it's Dr. Ivy Brandon here, naturopathic doctor in New York City. Very excited that we are having another live interview. So last time we interviewed Deb Flashenberg of the Prenatal Yoga Center, who happens to know today's guest. So today's guest is, sorry, before we even get into the introductions, I just wanted to say that we will be having our interview and then we will be opening it up for a Q&A after. If this is your first time watching one of our videos, definitely don't forget to like, subscribe to the YouTube channel. And yes, so I'm excited to welcome Tanya Wills, who is a certified nurse midwife, women's health nurse practitioner, and international board certified lactation consultant. She is the owner of Manhattan Birth in New York City, where she and her team have helped thousands of expectant and new parents with heartfelt, down to earth, no purple crystals, classes, support, and midwifery care in the childbearing years. Her techniques produce confident new parents who birth, feed, and parent their babies with gusto and pride, tackling anything that comes their way. Tanya is a graduate of the midwifery program at Yale University. Known for her accessible, no-nonsense approach to childbirth and women's health, she is featured expert on Yahoo
That's a pleasure.
Lifestyles, Know Your Body series, Cycles and Sex, and has appeared on expert panels at The Wing, Cycles and Sex, and Choices in Childbirth. She has been featured in the New York Times, Fatherly, and interviewed on the podcasts Wild Womb and Yoga Birth Babies, which is Deb Flashenberg's podcast. Amazing podcast, by the way. She is a former actor and musician, which I think is how you know Deb.
That's how I know Deb. We went to college together. Yeah.
Yeah. Tanya was called to midwifery after the birth of her first child in 2008. She splits her time living between Manhattan and Connecticut with her two teenagers and her husband, which I think when we had first met, they were probably only like 3 and 4 or 5. It's kind of crazy how time
Yeah, we met a long
flies.
time ago. They were
Yeah.
babies, but now they're, doing their own, they take care of themselves mostly now, which is nice.
Amazing. And Tanya practices as a home birth midwife, which is basically what we're going to be focusing on today, but also provides full scope midwifery, including gyne care, abortion miscarriage management, IUI and fertility, gender affirming care, and lactation consultations through Manhattan Birth Midwifery. So I'm so excited to have Tanya on today. This is a very topic that I'm very interested in, home birth. So let's kick it off. You have a very interesting background, and I'm curious, how did you become a midwife, specifically focusing on home births? Because you exclusively do home births, is that correct?
That's right. Yeah. I'm not privileged in any hospital and I never have been. And I did my training in the hospital and I love the hospital for many reasons. That's not where I primarily practice. So, first of all, I just want to say like how delighted I am to be here today, to be able to talk about home birth. I think there are a lot of like myths and misconceptions about midwifery care and about home birth midwifery specifically. And I hope that this will clarify for anybody who's interested in this topic today. So, and if you feel confused about midwifery and about home birth midwifery, you are in very good company, as most people that I talk to. So you don't worry about that. Indeed, my background is as a performer, and to make a very long story short, I was doing that and teaching some of the performing arts, that kind of thing. And I became pregnant about a year after I got married, and I didn't know anything about this. I mean, at all. And I kind of asked people, and it's probably no surprise to any performers that are watching this that there really weren't a lot of resources for me among my actor, musician type friends, because a lot of those folks don't have children or have them later, or this kind of thing. So I really just kind of went to my GYN that I had been going to forever, and she didn't deliver babies anymore. So she referred me to a doctor who I kind of felt like didn't know me at all. And I think through that, I started looking for better care, and I didn't know where to get it. But through sort of meeting people and talking to people, I eventually landed when I was 34 weeks pregnant in the office of my home birth midwife.
What? Really?
Yeah,
Wow, that long.
yeah. I
Wow.
mean, I thought that home birth was for crazy people. Like, why would you do it? And you don't you want to live? Like, why would you like, have a home birth? Like that must be so dangerous. It must be just emergencies after emergencies. But every time I kind of went to a different provider, and I switched several times to try to do something sensible, like have a hospital birth. And I I just didn't feel seen. I
Mm.
just didn't. And so, you only get 9 months to figure out where you're going to have the baby. And that's where I landed. And so I met my home birth midwife at 34 weeks pregnant, which was fine because we had lots of visits until I had my baby at 42 and a half weeks pregnant. Do not recommend. Um, and it was the hardest thing that I ever did. And,
Mm.
I always tell people, like, I'm a totally regular person. My favorite food is Doritos. This is not a thing that I always knew I wanted to do. You know, it just was what made sense to me at the time. And, what happened to me is that, I didn't get into home birth. I didn't have a home birth because I was looking for to have like a spiritual transformation or because of anything like that, but that is what happened to me. And what happened was that I did something that day that I had no idea was possible. I faced challenges in that labor. It was long and hard and all the things, right? And I waited forever for the kid. um and my midwife believed in me more than my own mother. She believed in me in a way that no one I had ever known. She knew things about me that I didn't know about myself. And that was a wonderful way to become a mom.
Mm.
And that's how I began mothering my child. And I was just like, what is this? I remember sitting on the couch with my baby, and, my midwife is sort of charting and my doula is cleaning up, and I just was like, this is what you people do for a living? Like, you give people a chance like this? And they were like, yep. And they just like cleaned up and, took care of me and then left. And ever since then, I was fascinated by the idea that somebody's life could be devoted to this type of work. And so I became a doula very shortly after that. And in case you probably know this if you're watching other ones of these, but a doula is a labor support person, a lay person who supports people through their labors and sometimes postpartum as well. So I did that so I could learn more about childbirth, about what it is to work in childbirth. And, I think I always knew that I wanted to be a midwife, but I have 2 degrees with FA at the end of them. And if you have a degree with FA at the end of it, then you know that I hadn't taken science since I was 16. You know what I mean? Like it's very specialized. Um, but I was very much called to it. I mean, as a doula, I felt like my hands were tied. I wanted to be able to do more for the people that
Mhm.
were in front of me, and I was just really interested in it. So I had another baby, and then I applied to midwifery school, and so I got
Was
accepted.
that other birth also a home birth?
Yes,
Yeah, just curious.
yes, but I knew as soon as I peed on the stick, I knew what I was going to do. That was very different. And that's a whole, I mean, I'm not gonna tell my whole birth story with Charlie, but my midwife, second babies are so different from first babies in terms of labor. The second baby is the baby that when they do all of the studies about labor and what it's like, the lowest risk person is the person having the second baby. That is always going to be the most straightforward labor. But I still, it's still long labor. I didn't believe my midwife. She's telling me this, and I had my first baby in like, I don't know, 42 hours, and the second baby in like two and a half, so there I was going like, who am I, like, as a birther? But as soon as he was born, I filled out my application, and I went right when he turned 2. I started midwifery school.
Oh, wow. That's amazing.
Yeah,
And
and I think, like, for me, like, you know, I did I mean, I had attended many, many births in the hospital as a doula, obviously, because that's where 9% of the people have their babies in this country,
Mhm.
right? So I had been to many of them, and I was sort of like, oh, I wonder if I'll want to work in the hospital. And I did all of my training in the hospital, and it was great. And I had wonderful midwifery preceptors who taught me so much. And then when I graduated, my own midwife offered me a job in her practice. And I think I always knew that that's kind of where I wanted to land. And so I was able to work with her for like the first couple of years as a midwife under her sort of wing.
That's amazing. And I think you touched on this, and I think most of our viewers now, for the most part, I think understand like the difference between a doula and a midwife. But maybe you could even touch upon like what are some of the differences, but also similarities between a midwife and an OBGYN. Are there things that midwives can't do that OBs can do, and how are those and how the roles are similar?
Yeah, sure. I mean, they're similar in that we both deliver babies. We both deliver GYN care. If you need a pap smear, you can go to a midwife. You don't have to go to an OBGYN. Um, so a lot of the services that we provide are similar. The difference is the approach. So midwifery care views childbirth as a normal part of a person's existence and lifespan, as is menarche and as is menopause, right? These are normal things that people will go through. And so sometimes they also become a medical event, but they don't usually. So what we do as midwives is, we're highly trained in how to handle complications and all this sort of stuff, because the truth is, when babies are just coming out, you really don't need me to do all that much besides just make sure that you're okay and affirm you.
Mhm.
um, but we're always thinking about, like, is this normal? Are my specialty skills needed in other ways? What we are not is we are not surgeons, right? So you'll find a difference in the training between doctors and midwives, because doctors are really trained in medical school as generalists, and then they specialize in residency, right? And while they're in residency, of course, they spend a huge amount of time learning to do surgery. And those are things that we don't do. So midwives are specialized just in midwifery, right? And there's a couple of different ways you can
Mhm.
go about getting your training. Some people do nursing school first and then they become a midwife. And some people don't. And there's other courses that they take to kind of fill in the gaps. I always joke and I say, because like you really don't need to like help a 75-year-old guy in urology, like, to become a midwife. Like, you don't. They're not related. So some people don't go that route. That's a perfectly fine way to get a license and become a midwife. So yeah, so that's the main thing. And so the approach, they call it a holistic approach. And whenever I talk about holistic care, I talk with people that holistic means the whole person, the whole family, their whole circumstance, and their whole life. It doesn't just mean herbs
Mhm.
and things like that. Although, that's part of our training for sure, but it's bigger than that. And it's also medicines, and it's also, who is this person? Where are they coming from? And we use a model that's called shared decision making, which means, in patient-centered care, that we are meeting you where you are. We're explaining what the offering is for the standard of care at this time in your pregnancy, and then sort of seeing where you're coming from, and walking with you through this process to help you come to decisions that make the most sense for you. So hi, beautiful people, whoever just said that. Um, so that's really the difference in the approach. Physicians are going to spend the majority of their time learning how to do surgery, because surgery is complicated. Childbirth is not. So we sort of spend our time basically working on more holistic care and, of course, identifying emergencies and complications and those kinds of things as well. All midwives work with physicians. Not all physicians work with midwives, right? Because what if you have a midwife and you need surgery?
Right.
There's got to be somebody easily accessible for sure. So all midwives have close relationships with physicians and also hospital. If you're a home birth midwife, hospital practices. If you're a hospital-based midwife, of course, there's physicians right there on your unit. If you're a home birth midwife, we also have physicians and midwives in the hospital that we work with. The difference is that we're always thinking about how long is it going to take for us to get there. Right. So we assess things a little bit differently than they do in the hospital setting because we do have that distance between us and the hospital.
Mm. Now, I don't know if you'll be able to answer this or you have any thoughts, but do you feel that there has been like a paradigm shift with the hospital midwifery practice versus the home birth, like kind of losing some of the roots of midwifery, and maybe you disagree, agree, uh, and or if you have any thoughts on that, and like in sometimes, at least from patients of mine, feeling that they decided to go with the hospital midwife because that seemed like this like middle like of the road, but that they felt that their experience was very interventional, a lot of fear. So I don't know if you have any thoughts on that.
Yeah, I do. And, you know, I think that, I mean, most midwives practice in the hospital, like, I don't know, 92% or something, I think is the latest number for the number of midwives that practice in the hospital setting. It it might even be more than that at this point. It's almost everybody. Um, and they do wonderful work and they bring that shared decision making model into whatever setting that they're in, right? So part of the reason why I don't work in the hospital is because there are players in the hospital that have never met you before and have no say in your care. They don't know anything about you clinically. And yet they are making calls for the way that care is delivered,
Mm,
right? They're making calls about, when an induction is recommended. They're making calls about how that induction is recommended, right? Because there's a difference between recommending an induction and there's a difference between coercing somebody and calling them over and over and over and over again until they consent to that induction. And
mm,
obviously, like that's not midwifery model of care, but pressures definitely come from behind them, right? There are people, midwives in the hospital are not just independent, right? They're working within this sort of structure and there's a push and pull that they have to do. And, midwives are people, and this is true about home birth too. Like midwives are people. There are some midwives that are more medical and some midwives that are less medical. There's some midwives that are really, really savvy at like helping clients have a more natural experience in a system that is not really designed to help you have a natural experience. They're just really, really good at that. And there are other midwives that are in hospitals where that doesn't seem as possible for them. There's a lot of talk in midwifery circles about bringing true midwifery, back to the hospital. And, I don't, pretend to be the definer of what true midwifery is. Only the people in the hospital that are practicing know what their challenges are that they face. I know a little bit about it just from my training. But that's what I sort of see too, is that they have a lot of power to a certain point. And then at that point, they're sort of like subjected to what the protocols are. And if you're at a hospital that induces everybody who's 35 years old at 39 weeks, then there you are,
mm,
and that's going to be a recommendation. And how that recommendation is presented to you, whether or not it's presented in a way that you feel that you have agency over that choice is going to vary from midwife to midwife and from place to place. And, people are going to be making their decisions about how they deliver this news to people based on what's behind them, pretty much, and their experience and things like that. But I do think that midwives in the hospital get a really bad rap. And I
mm.
think part of that is because people think that they're going to get a home birth midwife in there best of both worlds, right? I'm going to have a home birth in the
Right.
hospital. You're not. You're having a hospital birth with a midwife. It's still a hospital birth. Like, I don't mean anything by this, but it is what it is, right? So what you can expect is that you're probably, hopefully, going to get a little bit more time in your visits. But there are plenty, I mean, certainly in New York City, there are plenty of wonderful midwifery services that are doing those 10-minute visits with people because they're so busy and they're covering so much of the care. So I think that there is a lot of sort of miscommunication about the way that different practices work. And I don't think that people really have access to be able to understand how those things work. And I'll just say the best thing you can do is ask your doula what's happening in there. She knows.
Yeah, absolutely. And some of the things that you touched upon. So it was like last month we interviewed Caprice Abowit of Birth Smarter, and they cover a lot of these topics, and that's one of the reasons why I recommend a lot of my patients to take their birth classes, because they go over all these different scenarios and being prepared for like these difficult decisions and um, and in that whole process. But I also wanted maybe, I think it would be helpful kind of, because we're focusing on home birth with a midwife. We're not talking about going rogue, and not that I have opinion either way. We're basically discussing working with a midwife for home birth. Perhaps, Tanya, you could kind of give a picture of sort of what it looks like as far as not just the actual birth itself, but the your visitations, frequency, and which follows the typical mainstream prenatal visit check-ins and appointments, and maybe kind of just give like a overview of what that process looks like.
Yeah, sure. So the process of prenatal care in terms of number of visits is exactly the same as the standard of care for any OB, right? So we follow that calendar, the same as for a hospital midwife, same as a home birth midwife, right? So in the beginning of your pregnancy, it's about once a month. It might be a little bit more frequent in the very beginning if you're doing some dating and viability scans, if you're doing genetic screening on your baby. Sometimes you have a few extra visits because there's certain timing that you have to do around those things. But then generally, for the rest of the first trimester, it's once a month. Second trimester is once a month. And then in the third trimester, it's every 2 weeks until 36 weeks. And then it's every week until you have the baby. We offer all of the same laboratory testing, all of the same ultrasounds. We offer everything to everybody, all of the same vaccines. We offer everything that is the standard of care. And then people will come to decisions that feel right for them, right? So I think that the main difference is not just, okay, you're 10 weeks today, go get your blood drawn. That's one approach. And then
Mhm.
you have no idea what they're testing you for. You don't even know if you want the information. You don't know what it means, right? Was your blood work something that's reassuring about your pregnancy? Was it not reassuring? What is the case for you having a healthy pregnancy here? And how do you know that? For some people, they don't want to know, and it's fine. But I think that there are a lot of people that really do want to understand what's going on with their body. They really want to understand what the context of risk is in their pregnancy. And so that's really the approach that we take. There's benefits and risks to basically checking for everything, right? And for one family, checking for things is going to make a lot of sense and it's going to feel really, really good to them. And for another family, it's not. And they all have, I mean, just as long as we're talking about home birth with a midwife, even if we talk about a home birth without a midwife, right? So he does what they call that. Now they're calling it free birth. They used to call it unassisted childbirth. Now they call it free birth. They have personal reasons that they're doing those things, right? And so I think that what we're doing is including people's sort of personal understanding about their pregnancies and about their lives and their values in every decision that they make along the way. And so what that is in my practice is visits that are about 45 minutes to an hour pretty much every time. Once in a while it's a half an hour.
And it's at the patient's home, or do they have to go to your office,
It's
or?
both. Yeah. So in my practice, we have three offices. So people come to our offices just like you would for any other, place that you go in your life or a doctor you would see or whatever. All of our equipment's there. All of our laboratory testing is there. Anything that we could possibly possibly need is there.
Yeah, and you have to
Um,
ultrasound, or do you have to send your patients out to a radiation specialist?
So we have an ultrasound in the office. We have like a bedside ultrasound, very much like any OB or hospital midwife would have. We can check fetal positioning with that. We can date a pregnancy with that. Things like that. Check fluid, things like that. But what we do is we send people to usually to an MFM or to a physician's office where they have higher tech ultrasound to check for, like, say, the 20-week anatomy scan. That's when they're checking for like all the sort of parts and pieces of the baby. They're looking at like the valves of the heart. They're looking at the connections of the kidneys, and that is beyond my my purview. And so we send them there. Usually, if people do a 20-week anatomy scan, which overwhelmingly most people do, that they get sent out for. And if they decide that they want to do a 12-week nuchal translucency screening, which is an ultrasound where they measure the back of the baby's neck to screen for Down syndrome, then we send them out for that as well. But, in terms of like if you have a 7 or 8 week pregnancy and you want to see if there's a heartbeat and you want to measure it, we can certainly do that in the office.
Wow, so it sounds like, I mean, you're doing basically all the same routine testing that you would
We're
have.
doing the same routine testing. The difference is that we are offering it routinely,
Right.
and then people will decide what they're going to do. And I think that that's a major difference in paradigm. I think is that, you know, uh, I think that in most OB offices, people are just told what to do. This is next, this is next, this is next. And we'll say, this is next. Do you know what this is? Would you like to know what this is? What do you think of this? It's our routine to offer you this now. And the truth is, in our practice, most people want most stuff. Like they want to know how their pregnancy is doing. They want these screenings. They want to make a case for their low risk home birth. And prenatal screening is very much a way that we can do that for people.
Mhm.
So they come to our office. And then we also do some virtual visits. Like, for example, if someone's having their 20-week ultrasound, that's a pretty long ultrasound. Someone's looking at the baby for like a whole hour. You don't need to also come in. We could do a virtual visit, like for that, to go over those results together. And then at the end of the pregnancy, right around 37 or 38 weeks, we do a home visit. So we come to their home. We check out the joint. Everybody who's going to be at the birth is at the meeting, and we sort of go through like top to toe when to call us and how to set up the tub. What does this look like? What does the postpartum look like? What is that week going to look like? We get a tour of the home. We figure out where we're going to put the tub. Most people have a tub that we lend them. Yeah, and just kind of like plug in and get ready for the birth. We make sure that we know what is the nearest hospital that has OBGYN 24/7. And if we need a hospital that isn't the nearest one, like if we can kind of pick anywhere that we go, which is sort of that's sort of what we do if somebody's just having a long, exhausting labor, then sort of the opposite of an emergency. It's like nothing is happening and we'd like more to happen. So in that case, we can kind of travel anywhere that we want. And there are certain hospitals that are more conducive to giving people a little bit more time and space than others.
Yeah, I think that's really helpful. And kind of back to the birth experience, what are, I guess, both from like a pain management, safety management, what are you able to bring, or what are you bringing with you? And then I guess what are the options that would be only restricted? Obviously, we know a C-section is only going to be happening in a hospital, but maybe talk about some of the interventions that patients can access with a home birth and which are only at a hospital.
I'm so glad you're asking this question because
Oh,
I think for me, like when I was pregnant with my first baby, I thought, well, if you have a home birth, then you have nothing. Like that's what I thought. I was like, oh, they don't bring anything. Like, that's crazy. Like, but in fact, that's not the case. So from a let's just talk about pain management for a second. I think that anybody who is thinking that they want easy access to an epidural very quickly, if they want one, should plan a hospital birth. Epidurals work great. They like take away your pain. Most people in this country are going to birth with an epidural. You're in good company if that's you. They do work really, really well. And people are mostly having vaginal births with them, right? So I just wanted to say that, like, if that's you, if there's any part of you that's like not sure if you're going to want an epidural And when I say want, meaning get one, you should do that in the hospital for sure. Home
Okay.
birth is for people who basically what they're saying to us is if my labor is normal, I want to have the baby at home, right? And normal labor is really painful. I know that that's not like popular on like the socials. I know it doesn't sell books, to tell people that this is going to be really hard and it's going to be the trial of your life and it's going to be really painful, but it is. So even normal labor, even a 5 hour labor, like, I had my 2.5 hour labor with my second baby. I'm very happy I'm not in labor right now. I never met anybody who was in labor who wanted to stay in labor because they were just like so full of pleasure. Like, that's not a thing. So that has to be said. Like, we have to be honest about what that is. That being said, what we can offer for pain management is familiar surroundings,
Mm.
your turf. We are working with you. Whatever you bring, we are going to work around that, right? So there's not going to be a time where we say, we have to monitor the baby, get on your back and get into bed. That's not a thing, right? We're going to, wherever you are, if you're hanging over the side of the tub, if you're in your shower, if you're leaning over your kitchen counter, whatever it is that you're doing, if you're squatting on the floor, we're going to get on the floor and listen to your baby. Like, we're going to work with whatever your body's messages are giving you, and you're going to be able to follow those messages. And finding your way through that pain in that way is what makes it manageable. We can't take your pain away. We can't, but we can help you make it manageable. So that certainly is one thing, being free to eat and drink as you choose. I mean, keep in mind that nobody in active labor is eating a sandwich. You're not going to want a sandwich and in labor. But I mean, being able to sip things and take bites of things and get into your own bed if you feel tired, which people do in labor. And of course, I would say the main pain management tool that we have is the birth pool, right? Or the birth tub, right? So it's this glorified kiddie pool, right? That we blow up in your home when we fill it up with a hose that we connect usually to your shower, but sometimes to your sink. And there's warm water in there, and it helps you to relax your muscles. And it also makes it so that you're no longer responsible for holding up the gravity of your own body, which is fantastic at the end of a pregnancy to just become weightless. So that is really helpful for people. And I would say, I mean, it's got to be 95% or more of the people that we take care of are going to get in that tub sooner or later. Will they have the baby in there? I don't know. They'll figure it out, and they will or they won't. And it's fine with me, whatever they want to do. But in terms of like dealing with the pain of first stage labor, the dilation part of labor, the tub is very, very useful. We also bring pain medication, specifically like lidocaine injections, right? Like numbing medication, in case you need stitches after the birth.
Mm.
So with that, well, I'll just sort of back up again so that way I can talk about like sort of what we bring, right? So just like the hospital, we have all of the things to check your vitals, right? We have our ultrasound if we need to double check the position of the baby. We have a blood pressure cuff. We have a thermometer. We have, a pulse oximeter. We have all those sorts of things that they would have in the hospital to check on you, right? And we check on you, usually every 4 hours. We take a full set of vitals on people. We bring I just happen to have one sitting right here. I'm in my office right now. We bring a handheld Doppler, which if you're birthing in the hospital, they put you on continuous fetal monitoring, right? So that's basically this, except it's all the time, right? So it looks a little different. It's a flatter transducer, and they put usually belts around your belly so they can monitor the baby's heartbeat at all times. But what we do is we use what's called intermittent auscultation. So intermittent meaning from time to time. I hope I'm still going because I don't see you.
Yes, I
Okay,
don't
good.
know why. Yeah, I'm
Okay,
frozen
good.
for some
That's
reason.
fine. I'll keep going. So intermittent meaning from time to time, and we do have a specific protocol for that. So we have a protocol in my practice that we get from larger organizations. And so that is, we listen to the baby in a very specific way about every 15 to 30 minutes in first stage labor, depending on what we hear. And then usually every 5 or so minutes during pushing, or maybe every other push, depending on what we hear. If there's anything that we need more information, we listen more, right? So we do it a little bit differently than continuous monitoring. And all of the data has shown, all the studies have shown that in low risk pregnancies, doing intermittent auscultation is, you get an equal amount of healthy outcomes with fewer interventions, right? So continuous fetal monitoring exists for people to intervene on you. That is what it is there for, right? So anything that they see, they must act upon. We're looking more at a holistic picture of how the baby is doing. Yes, we're listening, but not at every single second. So that's what we do. We also, so you have your baby. We bring, a birth kit with us with all the same tools that somebody would have, an OB would have on their table, including episiotomy scissors, which, I've been a home birth midwife 11 years, putting episiotomy scissors on my tray, and I have yet to feel that I need to use them, but there they are in case they're needed. What we don't have for delivery that the hospital has would be something like a vacuum or forceps. We don't have that with us. We give people all the time that they need to push out their babies. And again, like, we're listening to the baby in a way that is sort of looking 10 steps ahead of the game, knowing that if this baby is going to need help, we're good, like a vacuum or a C-section, we're going to need some time to get there. So, we have sort of a low tolerance for going to the hospital. All of that being said, about 95% of the people who plan a home birth will have their baby at home. There's not, most people don't transfer, they just have their babies at home. So we bring IV fluids with us. We're
Mm.
skilled at placing IVs. We bring antibiotics. We bring dextrose and other things that can kind of support you through labor in case you're throwing up. We bring medications like Zofran, right? So some of those things are things that they have in the hospital as well. And then after the baby's born, we have our full resuscitation equipment. We're all certified in neonatal resuscitation practice. So if the baby comes out and decides that they're a little stunned and they are a little blue and they don't want to breathe right away, we know exactly what to do, and we do it, and we're very highly trained in it. So we have all of that. We bring oxygen, we bring all the suctioning equipment, we bring, advanced airways, all that kind of stuff that we bring in case the baby needs it. And then, we bring sutures, we bring lidocaine, we bring IV pain medication, and we bring all of the anti-hemorrhage medication, the exact same stuff that they have in the hospitals. We bring Pitocin, misoprostol, Methergin, TXA, exactly the same stuff. So we have that as well. I'm probably forgetting some stuff, but yeah, maybe you'll ask me about it. But that's sort of the gestalt of what happens. And, that's really why you have a midwife, right? I mean, that's why you have a doctor too, right? Is if there's anything that needs intervention or attention, and Tributylin. Thank you, Sarah. Tributylin is something that we can offer to somebody. Let's pretend they're having really strong contractions and the baby's not tolerating those contractions. And every time you have a contraction, the baby's heartbeat is just really
Mm.
going down and it's really just getting really intense and time matters. We can stop those contractions from happening while we're transporting you. And that's what Tributylin is for. So it's another sort of tool that we can use if we need it, in a situation where time really matters and we want to make sure that the baby's not having too much stress put upon it. So thanks, Sarah, for that. I really appreciate it. Sarah's my work wife. We work together in,
Oh,
in
nice.
practice. So I'm glad that you're here to help me out. Um, yeah, so that's basically what we carry. And then of course, after the baby's born, we have a whole protocol. We usually stay about 4 hours after the baby
You
is
That
born.
was what I was going to ask next, so that's great.
Yeah, to just make sure that everybody is stable and well, right? If there's a bleed, we take care of it. If there's stitches, we take care of it. If the baby is needing suction, we take care of it, right? Like, we take care of all of those things until everybody is bored. And and together in their bed. The baby will nurse. 100% of our people nurse their babies, unless there's some massive medical reason that they can't. I mean, I guess they could have personal reasons that they don't too. That doesn't usually happen. but babies are born alert. There's no medication in their systems. And they do the breast crawl and they nurse, and everybody 100% nurses, and it's not an issue. None of the babies get jaundice because they're also well fed and they don't have any medications that they're working through their systems. So that's not an issue. We do check the baby for jaundice though, just in case. In 11 years, I've had one baby that needed treatment. And she had some other stuff going on too. But in any case, we stay about 4 hours. We do the congenital heart defect screening. We do the newborn screen 2 days later. We do the bilirubin check. We do the hearing screen. We offer vitamin K and eye ointment to families who want that. We have those in our bags as well. Yeah, and we usually we call the person the next day. We give very specific instructions about lactation. We call the person the next day. We come see them on day 2, and then the other midwife will come see them around day 7, and we'll be in touch over the phone. We also have in our practice unlimited lactation support, so nobody has to go looking for a lactation consultant. We're all lactation consultants in my practice, and so if somebody needs help, they can either get it from us virtually or in person, or we'll send somebody from our team.
Okay, so I have a lot of questions now, and I'm trying to think what would be the most important. I guess like just from a couple of some like logistical questions. So the first is insurance, health insurance. Does it cover home births? How is that process? Are there any insurances that wouldn't? I mean, do you take Medicaid patients? Maybe talk about that for people who are thinking about financing the finances.
Yeah, I think these are great questions. And so I just want to say that if you're not in the state of New York, what I'm about to say
My bad.
very likely does not apply to you. So, in the state of New York, we have a law on the books that makes it so that any person can birth with whatever kind of care provider they want, be it a physician or a midwife, and wherever they want, in the hospital, at home, or in a birthing center. And insurance has to cover it. Insurance isn't allowed to say we don't cover home birth, we don't cover midwives. That's not a thing that can happen in New York. And what's wonderful about that is that it's also true for Medicaid. So our home birth rosters in New York City and state are reflective of the general population in terms of Medicaid, which is about half the births, right? So about half the people we take care of, Medicaid is the primary payer. And then I would say probably, I don't know, another more than 3/4 is going to be primarily insurance. And then once in a while, somebody has an insurance company that's from another country or some state that doesn't allow home birth, or they work remotely for a company in fill in the blank state, maybe Nebraska or something like that. And in those cases, we work with payment plans and sliding scale for folks.
Yeah, I think that's helpful. And another like logistical question, and this might be very specific to New York, and since you work with a lot of New York patients, uh, we live in amongst many people. We live in apartments, maybe smaller apartments, maybe bigger apartments, lots of neighbors, maybe multiple children. Like logistics around that. One of the one of my husband's things against potentially home birth was me screaming and like disturbing the neighbors, and that was one of the reasons why we didn't end up going the home birth route versus some other things. But maybe just like some of that, like basic logistical things that you've encountered. Specifically, I'd also
Yeah.
about like
So
how
I don't
childcare.
know. Yeah, I don't know how many New York City home births I've done. It's many hundreds, and it has never been an issue,
Hmm.
ever. Do people ask me about it? Almost every time. Everybody asks me about it, right? The most common things that I hear from people is like, "Oh, is it going to be loud?" Right? Or, "I live in a small apartment." I mean, have you been in a hospital room lately? Like, they're not big, guys. Like, and also like, is it going to be too loud? And I would encourage folks that if you have questions like this, you definitely want to speak directly to a home birth midwife rather than assuming that the city is flooded with police reports about people who are having babies in their apartments, because it is absolutely not the case. So in all of my time, 11 years I've been doing this, I only one time had a doorman that knocked on the door, and these folks lived on the first floor, right by the doorman, and the doorman knew that we were having a home birth, right? So, he heard the labor happening and he knocked to see if he could help. Other than that, I have never had anybody knock on the door, send the cops, say anything. Frequently, what happens is people have their babies and their neighbors go, "Oh my gosh, you had your baby." And you say, "Yeah, I had the baby right here at 8:30 yesterday morning." And they go, "Oh my gosh, I didn't hear a thing."
Wow.
Yeah. So that's just, I think most home birth midwives will tell you that that's the case. I'm sure all of them would. It's really, we all talk about the different challenges that come from doing a home birth. Sometimes it's like, where are you plugging in the hose to fill the tub? This person has a problem with their faucet, or different kinds of logistical things, but noise is not one of them.
Interesting.
Yeah, yeah. And then in terms of like if there are other children that are in your family, each family can decide what they want to do about that. One option would be to have your child go somewhere else, which is what you would do if you were planning a hospital birth, right? If you're planning a hospital birth, you'd have to try and figure out what you're going to do with your kid, right? And then head off to the hospital, right? In home birth, some people do that. They have, grandma, neighbor, whoever come pick up the kid, and they're going to have a sleepover. It's going to be great. And sometimes children express a desire to be present for the birth, right? And so in that case, what we do is we prepare the children for the birth, right? So we explain to them what it's going to be like, what it's going to sound like, right? Mom's going to roar like a lion to get the baby out. Roar with me. Roar. Let's roar together. Rah! That's what it sounds like to have a baby come out of you, right? So we also send them videos of animal births, right? So in case the kid doesn't know where the baby comes out. So it sort of starts these discussions, and then they move into human births, and we prepare the child for how they can be helpful. Usually the child will help me and Sarah with listening to the baby prenatally, taking blood pressures, and they really kind of get to know us so they're comfortable when we show up at their home. And then at the birth, the most important thing is that a kid can be a kid, right? So if you have, say, a 3 or a 4-year old that is expressing interest in being at the birth and they're well prepared for that, they know what that's going to be like, you know, they still might want to go play, or it might get too intense for them. And they're just like, okay, I'm all done in here. Like, I'm going to go watch a movie, or I'm going to go play with my toys, or be on my iPad or whatever. So that's totally fine. We just make sure that there's an adult in case the child needs something like a meal prepared or anything like that. But ultimately, the ultimate decision about whether the child is in the room, I mean, that's the child's choice. And so we just prepare the home for that.
I think that's helpful. And maybe I should have even asked this question earlier, but I think it would be helpful. Who's, I guess it's a kind of two part. One, who is not a candidate for home birth? And then also in the process of working with a home birth midwife, when is it time to switch over to a hospital birth? Not necessarily when I'm talking about like emergencies that are occurring during the laboring process when you're actually there, but even maybe before, like at the 30th week. So maybe touch on some of those.
Sure thing. Um, well, first I'll say this, that I'll just talk about transfer for a second. So there are lots of reasons why people can transfer, right? And we're looking at like maybe 5% of the people who plan a home birth are going to transfer. Some of those people are going to transfer prenatally, right? They're going to transfer before labor even happens. And usually that's because there's some complication that comes up in their pregnancy, right? Maybe it's because they develop a condition like preeclampsia or hypertension or cholestasis, right? Um, Maybe their baby is breech and they're with a midwife that doesn't feel comfortable doing breech, or they don't feel comfortable having a breech home birth, right? I mean, you're already crazy having a home birth. Do we need to add breech into the mix? For not for everybody, right? So there are different reasons like that people will decide that we're gonna change paths, and usually the midwife will help facilitate that, right? The midwife knows everybody in town, is going to try and help this person figure out where the best place for them is, and then of course we'll facilitate that transfer of care. And then in labor, there's sort of two primary reasons, right? There's the one where time matters, which is the rarest, but it does happen, right? I would say the baby's pulling some bullshit, right? Like, okay, I don't, the baby's pulling some bullshit. I think we're going to be better off if we go there. Right. And maybe you'll just push out your baby and they'll scream and you'll be mad at me. But I've seen enough pink flags here that it's better to be in there by the pediatricians. Right. So we know those sort of markers. We pay attention to them. And then the other more common reason would be for somebody having a first baby and it's just taking an enormously long time. And that decision is made by the birthing person together with the midwife. Midwives don't make calls at like 24 hours that you have to go, right? It just really depends on the person and all of those kinds of things. So that those would be those things. And of course, like, I don't know, maybe the baby comes out and they can't really clear their lungs properly. We could bring a baby in. Maybe somebody has a postpartum hemorrhage that we stopped and they're stable and they're fine, but they're just kind of dizzy and having trouble getting stable, and we've done all of the things that we have. Maybe they need to go in for a blood transfusion. That's not an oh my god licensed sirens. That's, they're fine, they're stable, but I can't leave them if they're dizzy, and I can't move in with them, so maybe they need hospital, right? Hospital supervision, and maybe a blood transfusion, who knows. So that's those things. And then the other part of the question, which I've already forgotten, and you're going to tell me what it is. What was the first part?
Oh, I guess who's not a candidate, like from the very, like,
Yeah, from the
when we
get-go.
were considering.
Yeah. Okay, so the party line is that you have to be a low risk candidate and then you're good for home birth. I
What
don't
does
think
that
it's
even
that
mean?
I don't think it's that simple. You know
Mhm.
what I mean? Like, I think it's more complex, because what is risk, right? Like, somebody just the other day was saying, I have somebody who's 41 weeks pregnant right now, or a week past her due date. She's asking me, is it very risky for me to just wait for this baby, right? And I think it really depends on how you look at risk, right? As long as you're pregnant, there's risk. There's always risk, right? How do we view that risk? I mean, there are certain things that are just inherently high risk, right? You're having 3 babies in there. I don't think that's a good idea. I mean, I'm not gonna attend that. I'm not comfortable with that. Maybe there's a midwife who would. I'm not the one, right? Um, but that being said, the first thing I need to say is that here's who's not a candidate no matter what.
Mhm.
Anybody who doesn't want to do it, anybody who's scared to do it, and I mean really scared. I don't mean like nervous that they're going to have a labor. I mean scared, right? Anybody who has people who are going to be in attendance at the birth who don't think this is a good idea,
Mm.
right? So what we do in our practice is, if people want to work with us, they have to speak to our assistant first, and the first thing that she does is she screens everybody to make sure that if this person has a partner, that partner also thinks this is a good idea. Right. So we are not in the home birth convincing business. I don't convince people to have home births. In fact, I'll try and talk somebody out of it if I can smell it. You know what I mean? Like, this is a countercultural choice. Home birth is safe. So are C-sections, but they all carry risk, right? And how you view that risk is going to be very, very personal. And no one can tell you that being outside of the hospital is exactly the same as being inside the hospital. It's not. You're not there, right? And depends on how far you are. I always tell people, even if you are 5 minutes from the hospital, you need to know that you're not 5 minutes away from your baby being born, right? You have to get out of your house in labor, which is not fast, get in the car, go, walk in, be
That's
admitted,
good.
and then receive care, right? So all of this can take time, right? So that's something that you have to understand and be responsible for and accept if you're choosing a home birth. So that's, I think, really, really important. And any midwife that you meet that tries to downplay that, that's not fair, right? You deserve to be able to eyes open choose what you think is the best and own your decisions. And so that's really, really important. um you know do I think that you're going to get like struck by lightning and have to have the baby out in 5 minutes with no warning? I mean, no, that's extraordinarily rare. It's like 1 in a million or something like that, right? But it's not impossible, and nobody can tell you that it is. So that's really, really important. Otherwise, it has to do with how people view risk. Here are the things that I hear most commonly. In the state of New York, we can kind of do whatever we want. Anything that's in our scope, we can do it, right? So, if somebody goes past their due date, or their water's broken, or they have twins in there, or they have breaches in there, or whatever, it's not we're not doing anything against our licenses to attend births like these. So each midwife is going to decide what level of risk feels appropriate to them, right? In terms of their comfort level and who they will accept into their practice, right? For some people, breach is going to be fine. They have experience with breach. Maybe they practiced in another country and they did a whole bunch of breaches and it's just not a big deal to them and they're totally comfortable with it. For other midwives, they think if you're going to do a vaginal breach, it's better for you to be in the hospital, right? And some people will say there's no hospitals that do it. There are hospitals that do it. You have to drive to them, but they're there. So there's that. Some people will not do twins. Some people will not do VBAC. Some people will not do people over the age of 40. Some people will not do people with a BMI over 30. Sarah's going to probably post some more. This kind of thing. It's very interesting because people will ask me, in like an interview, right? Like they're interviewing me to see if they want me to be their midwife. They would say, they got these questions like off the internet somewhere, and they say to me, "Do you do breach?" Right? And my question to them is, "Do you?"
Mm.
It's the same question. Do you do home birth? Right? Like, what do you do? Like, if you have a breech baby at the end of your pregnancy that won't turn in there, right? It's not my job to tell you that you should have that baby at home. We're going to talk about the risks and benefits. We're going to talk about how we might do it at home. What are your hospital options? What could those things look like? We're going to talk about the countercultural choices and all of these things. I would never say, yeah, it's the same thing. Never. Who could ever say that? Sarah added that if you have hypertension, if you have chronic hypertension, you're not a candidate for home birth. It's too dangerous. You need to be on medications. And the same thing if you have type 1 diabetes or type 2 diabetes that needs medication or insulin. So those things typically are not attended at home.
Yeah, I think that's really helpful. And this has been one of the most thorough interviews I've had, and I've really, really enjoyed it so much, Tanya. What is the best way people can get in touch with you?
Through my website, manhattanbirth.com. You can just go to contact us, or if you think that you are looking for a midwife, you can go to manhattanbirth.com/midwifery, and all of our services are there, and you can contact us through that, and you can set up a consultation to meet with us. And usually you'll talk to our assistant first to kind of get some of the nuts and bolts talked about. So that way we together can have a more meaningful conversation about what it is that you want for your birth and whether or not we might be a good fit.
Thank you. And for anybody who has more questions for Tanya, we will be staying on for a little bit. I don't even know if she has any time at this point for a little Q&A after we finish things up. But thank you everyone for attending. My name is Dr. Ivy Brandon of Simplicity Health Associates, naturopathic doctor here in New York City. In December, I'm going to be interviewing a dentist, Dr. Nadia Rodriguez. We're going to talk about hormones and oral health. It's kind of interesting how that plays a role. And if you are watching this for the first time, don't forget to subscribe. Also, you can always feel free, if you're not able to stay on for the Q&A or you're watching the recording and you still had some questions, you can feel free to drop those in the chat of the recording of this. And also, stay tuned that my e-course all about getting pregnant in your 40s is going to be launching very, very soon. So you definitely don't want to miss that. And this is amazing, Tanya. I'm really, really so happy that you agreed to join us today.
Oh my gosh, you're so welcome. Thank you for asking this question, Julia. We'll get to this in just a second, okay? Oh, there's good questions in here. Okay, great.
Okay.
Thank you so much for letting me join you today. And I just want to say that, home birth midwives, like, we love the hospital. The hospital is what makes it possible for us to bring you someplace safe if you need it, right? So we have great relationships with the hospital. You're never going to get somebody who's like anti sending you there if you need it. And if you're planning a hospital birth, like, like, do your truth, man. Like, if you want a hospital birth, go get one. Go get a really, really great hospital birth. It's all good. And, follow your bliss.
Okay, so it looked like you saw some interesting questions. Did you want to answer them?
I see one from Julia. Hi, Julia. What if someone is tested strep B positive? So I'll answer that first. So we do offer screening for group B strep at the end of pregnancy, just as you would in any other office. Overwhelmingly, most people will accept that screening, but you do have the option to decline it. And by the way, you have the option to decline it in the hospital too. I'm not saying you should. I'm just saying they don't present it like you have a choice, but you do. You always have a choice, right? And you have a choice with us as well. So people who have group B strep, um, we look at their risk factors. And the first thing that we do is we present to them the option of what the CDC recommends, right? And so if somebody has group B strep, the recommendation is for them to receive 2 doses of IV penicillin each 4 hours apart before they have the baby to protect the baby from getting a very serious, rare, but very, very serious infection with group B strep. Nobody wants that for their baby, right?
Mm.
So, and I want to just sort of, well, I'll come back to this. So that's one option. Some people want to take more of a risk based approach. They say, if my labor is really straightforward and my doesn't break, and I don't have any sort of signs of anything, then I really don't want antibiotics, and I might change my mind. So can you bring them anyway?
Hmm.
Right? They're always in our bag. We don't, if you want them or don't want them, and they're in the bag, you know? So sometimes it's a little bit of a game day decision, they think that they're not going to want it, but then maybe they get into labor and they feel like they want it. Or they think that they're going to want it, but we get their labor so fast and we get there and there's no time. So that can happen, sort of, I think, with all plans for birth. That can happen for your epidural too. So make sure that you're planning for all things. Anyway, so that's sort of the approach. Are people in our practice required to take antibiotics? I think you know the answer. No, they're not. If they want them, we will talk through benefits and risk with them. Do we give them to people? Absolutely, we give them to people. That's no reason for you to transfer to the hospital. We're totally capable of giving them if you would like, and we're capable of monitoring you and the baby if you think that you don't want. And if you think you don't want them, and we suddenly see that you are very high risk, we're going to tell you about that. Okay. So just know that, like, we're going to walk with you on that journey. HSV2, asymptomatic, never had an outbreak, just lucky, I guess, right? Um, so HSV2, if you've never had an outbreak, that's fantastic. The recommendation is to start you on something like Valtrex at 36 weeks. We would explain to you why that's the recommendation, and we can prescribe that for you if you decide that you want to go ahead and take that medication at the end of your pregnancy. Most of the people that we take care of will take that medication at the end of their pregnancy, knowing that their immune system is not quite what it typically is when they're not pregnant. That being said, if you decided not to take the medication, would we still take care of you? And the answer is yes. We don't abandon. In our practice, we don't abandon our clients for any reason, right? So we may, talk to people about different risks that they're taking. Sometimes people take risks that we're like, maybe you should have this baby in the hospital if you don't want to do anything, because they're ready for anything. That being said, we do not abandon our patients for their personal choices. And so we can manage it together and find something that will work for you. So thank you for asking. Just know if you never had an outbreak, you're at a higher risk of having an outbreak during your pregnancy. It doesn't mean that you'll have one, though. It's still pretty unlikely that you're going to have one. Great. I'm glad that we made you more confident.
I'm not even seeing that.
Yeah. Somebody wrote, came late to this conversation, but it made me more confident and excited. Thanks, guy. They mean guys, but you're welcome. Good questions, though, Julia. We get a lot of those types of questions. Or like, what if somebody's water is broken for a really long time? Like, will you bring them to the hospital? You know, we don't have a limit on broken water. We also don't examine people, and we check their temperatures, and we follow like lots of anti-infection protocols, and we're watching them very, very carefully. That being said, in some states, once we get into state to state, it's going to drive you bananas. But in some states, they do have rules about if somebody's water's broken 24 hours, you have to bring them in. Some places close as New Jersey, you can't do a VBAC at home in New Jersey. You can't do twins at home in New Jersey. You can't do breech at home in New Jersey. So if we have anybody who, particularly VBAC, that's sort of a thing that sort of happens around here. We don't attend VBACs in New Jersey, but if they can come to New York, then we'll attend them.
Oh, interesting. Looks like we have another question. Sarah, it just disappeared.
Sarah, she's a plant. She's my work wife. Um, you did not have an outbreak last pregnancy and did end up taking the medication. Okay, yeah, good, Julia. So you can totally do it. One more thing I wanted to say about antibiotics is that if you decide that you want to take antibiotics for your groupie strep, we're going to also talk you through like how to like take probiotics and things around that to try to
Mhm.
replace some of the missing bacteria that kind of winds up out of your body. And also we talk about infant probiotics for the baby as well. And plus the nursing and everything also helps to kind of replace that. We'll talk with you about the microbiome. There's a lot of data on that and sort of long-term stuff about that. People are generally pretty worried about that. So we talk about that. That's your husband, Marlene. Is he worried about the microbiome? I understand if he is. Yeah, totally. I get it. I get it. It's a longer conversation, right? So where do folks find the best info if they're trying to decide on where to birth
Mm.
and want more info on home birth? Okay. So if you think you want a home birth, or you think maybe you want a home birth, but you're worried about things that nobody else has thought of, right? Insurance, noise, emergencies, all these sorts of things that we sort of talked about here, but you still want more information about it. There's a lot, there's a lot of things you can do. One thing to do would be to talk with a home birth midwife. They know exactly what's happening,
Mhm.
right? So that's going to be a terrific resource. I feel like there's a lot of sort of assumptions and myths that are out there about home birth that aren't really the reality of what's happening. And there's that. Secondly, I love there's a great documentary film that's called Why Not Home. Have you heard of that film?
No, actually, I've not heard of that.
Yeah. So a lot of people have heard of the business of being born,
Right.
right? So is a great documentary. It's a little heavy-handed, you know. Um, so Why Not Home is a documentary that's a little bit more boring. And it is about OBGYNs, family doctors, L&D nurses, and midwives who all deliver babies in the hospital who choose to have their own babies at home. So the documentary follows these families who are delivering babies in the hospital for a living, and they choose something else for their choice, and they really go through kind of a lot of this stuff. And you'll see not everybody winds up having their baby at home, right? So you'll see sort of like what something like that might look like. So that's a great resource. You can also go to nyhomebirth.com and just go to the resources section. There's a whole bunch of like scientific data and literature that's available for you. The outcomes of 16,000 American home births and like what those outcomes were like. And you can take a look at all of that.
Where can we actually watch that film? Is it
You can
like
watch it online. I think it's like $2.99 to rent it.
okay?
Yeah, yeah,
Sounds
yeah. It's
good.
called Why Not Home. Yeah, I think it's the best thing, you know. Um, Sarah will tell me if I forgot anything. No, he's the one who came late. Okay, Marlene, awesome. Do you outsource for your lab work or is that done in-house in your office? Yeah. So we do all of our own lab work, right? So we draw your blood, we take your swabs, and we send them off to the lab. And your insurance covers all your routine lab work, right? So there's no, depending on your insurance plan, but generally speaking, like we're not going to charge you anything extra for drawing your blood. That's all part of it. It's just like a global fee. Um, okay, next
One more.
question. What
Yes.
do I suggest for my patients that are more than 41 and 6/7 weeks? Well, the first thing I'll say is don't do that. Reason with your baby. I'll tell you, I did that myself personally. Do not recommend. And the reason I don't recommend it is because it's so hard on you mentally and emotionally. You know what I mean? So I think the first thing I should say is that whenever there's somebody who's 41 weeks pregnant, every day that they wake up pregnant is like a mental and emotional thing, right? So we walk with people through this very special, tender time, right? Everybody wants to meet their baby. The pressure is on from everybody, right? In our practice, we don't transfer people automatically at 42 weeks. I know that there are states that do that. That's not a thing that we do. Um, However, we talk with people right around 41 weeks about risks and benefits of staying pregnant, depending on their age and their risk factors, right? And sort of like, how do they feel about being pregnant? What do they want to do? Some people will choose just waiting. That's not most people, but some people will just choose waiting until an eternity. We had one this year.
Mm.
It took a long time. Baby came out, but it took a long time. Usually, people will choose some combination of waiting with ultrasound monitoring, where they do a biophysical profile and non-stress test to test for the well-being of the baby, and wait with that. And sometimes they will combine that with certain things to try and help the baby come, right? And so lots of people have heard of many, many things that you can do to try and help the baby come. And of course, as midwives, there's certain things that we can do that we can offer as well to help the baby come, right? We're not going to hook you up for a Pitocin induction, but there are a lot of things that we can do, right? So we have herbs, we have homeopathy, we have our labor smoothies, there's castor oil, there's acupuncture, there's membrane sweeps, there's breaking water, there's balloon catheters, and some other medications and things like that. There's pumping. There's so many things that we can do. And so typically, I mean, some people just like, they're like, okay, I want you to sweep my membranes, right? And I'm like, okay, great. Well, we'll do a membrane sweep. We do a membrane sweep. They have the baby that night, and it's great. And some people, it's like this protracted thing that whole week and sometimes even beyond with trying to get them into labor. But the thing that we have on our team at home is we have time, right? So we can try a thing, give it time. Try another thing, give it time, and you'll move through your pregnancy and see how you're feeling, and how interventive do you want to be or not, right? And we'll talk with you about the benefits of maybe trying a little sooner. What would the risk be of trying a little bit sooner? What would the risk be of waiting? What are the benefits of waiting? And we'll walk with you through that. So the answer to what would I suggest, the answer is I don't know you, but we'll have a good conversation about it. All the things.
Okay, so
So
we'll just take one more question because I have something
you
to
have
ask.
to.
So I will ask one more question and
Yes, yes, absolutely. Okay, so we have what kinds of supplies is the birthing person responsible for the home birth? I think that that's a really good question. And before I answer that, you can contact us for a home birth as early or late as you want. So just give us a call. You don't have to see a doctor first. We can take care of you right from the beginning. And if you see a doctor, then you can call us whenever. It's totally fine. Here's what we do. Um, the folks that we take care of are responsible for buying a box of stuff. And in that box is going to be things like, um, you know, maternity maxi pads, gloves, gauze, chucks pads for underneath all the things in your home, right? And a bunch of other things that are sort of consumables that we need for your birth that we're going to use. We bring so much more stuff with us, but usually in our practice, that box costs about $60. For folks that don't, that $60 is really hard for them, usually we can gather a whole bunch of that from leftover birth kits, and you only have to buy a couple of things. And then there are household items that you're going to need for your home birth. So that's going to be things like towels, right? We lend everybody a birth pool, but you need to get the liner and a hose, right? You're going to need like baby wipes, you're going to need a plastic shower curtain to protect your bed. So there's a specific way that we make your bed to protect your mattress. Plenty of food and drink, right? All those sorts of things. But yeah, I would say like probably depending on whether or not you're buying a liner, probably about $100 worth of supplies that you'll probably purchase, and everything else is usually gatherable, or the buy nothing group on Facebook, or maybe your mom's closet, those really thin towels that you don't even know why she still has them. Those are perfect for your home birth.
Thank you, Tanya. So this was our live Q&A after our interview all on home birth. And this is Tanya Wills, midwife, and I'm Dr. Ivy Brandon, Simplicity Health Associates. Hopefully you enjoyed the Q&A. If you want to watch the full interview, that's on a separate recording. And looking forward to seeing you next time. Bye.
Bye.
Okay. Well,